All right. Well, welcome everyone. I know people are just beginning to log on, but I thought we would go ahead and get started. I think we have a lot of content to cover today. So I just want to welcome everyone to the webinar. So thank you for joining us. Today we are going to be talking about a very interesting topic and exploring what the lasting effects of historical redlining have been on breast cancer risk and survival, how neighborhood conditions shaped by discriminatory policies nearly a century ago continue to impact health outcomes today. This work pushes us to consider not just access to care, but the structural and environmental conditions that influence cancer across the lifespan. So we're thrilled to be joined today by Dr. Sarah Lima, who recently completed her PhD in epidemiology and environmental health at the University of Buffalo. She also received her MPH in epidemiology from Columbia University's Mailman School of Public Health with a certificate in epidemiology of chronic diseases. Her research, both during her master's and doctoral training, has focused on breast cancer trends, disparities, and the social and biological mechanisms that link to economic insecurity and health, or link those two things. So today's presentation will draw largely on the work that she did for her PhD on historical redlining and cancer outcomes. So I will turn it over to Dr. Lima in just a moment, but what I would like to do is just call your attention to a couple of things. We do have an upcoming webinar on the 23rd, which I hope if you're interested, you'll sign up for. It's basically a recap of breast cancer trials that were presented. Some of the key results that were presented at ASCO 2025. We'll be focusing on probably about 4 or 5 key trials that were presented. So you can register for this on our website. We also have the Public Policy Academy training open. So if you're interested in participating in this next coming year's Public Policy Academy, which starts in September, please sign up. I mean, this is just it's a year-long program, but it's monthly Zoom webinars for 1 hour, and you learn about a number of different things. And this is particularly of interest to people who want to get more involved in our public policy work. And then finally, just to note that we look forward to a good discussion after Dr. Lima has finished presenting. So please feel free to ask questions. Use the chat or the Q&A feature throughout the webinar. Submit your questions. We'll get to those after Dr. Lima's done presenting on her work. And then you can also raise your hand if you want to ask your question. So again, we will go ahead now, and I will turn it over to you, Sarah. Let me just stop sharing my screen and let you take it over.
Okay. Is it showing up?
Yes, looks great.
Okay, great. Okay, yes. Thank you so much for having me. I'm really excited to do this talk. As mentioned, a lot of my research interest is on place and how neighborhoods can influence cancer and breast cancer specifically. And so what I'll be talking about today is historical redlining and how that has an ongoing influence on breast cancer risk as well as survival. Okay, so for the talk, I'm going to start with some breast cancer disparities, as well as go over how I like to think about social determinants and how they impact cancer, just for some context. And then we'll go into what historical redlining is, as well as the conceptual framework as to how it could theoretically impact breast cancer. Then we'll move to the 2 studies, the first of which is on breast cancer survival, and the second is looking at redlining with the clustering of breast cancer risk factors today. And then we'll close with some potential paths forward. Okay, so I'm sure this is something that all of you are well aware of, but breast cancer is the leading site for cancer diagnosis among women. And while it has a relatively high 5-year survival rate of 91%, there's still some major disparities that exist, with more than 92% of white women surviving to that 5-year point after their diagnosis, compared to less than 84% of Black women. We also see disparities according to stage, where white women are more likely to be diagnosed at the local stage, whereas Black women are more likely to be diagnosed at regional or distant stage. So looking among white women diagnosed with breast cancer, 67% of them are diagnosed locally compared to 57% of Black women. And then when we look at distant stage breast cancer, 5% of white women are diagnosed at that stage compared to 8% of Black women, so nearly double the rate. And then even within stage, we find that Black women face lower survival compared to white women, which really indicates to us that the lower survival statistics we see by race and for Black women are not simply due to them being diagnosed at a later stage. So specifically, we find among regional cases that 87% of white women live to that 5-year time point compared to 78% of Black women. And then for distant stage, 30% of white women diagnosed distantly survive to the 5-year time point compared to 20% of Black women. And when we're talking about breast cancer disparities, it's really important to think about how they've changed over time. So this graph is showing mortality rates for breast cancer from 1975 all the way to 2020, and it's done by race, with Black women being shown in the blue and white women being shown in green. And what we can see with this graph is that this disparity didn't exist throughout time, but instead appeared only in the mid-1980s. And that's really interesting timing because it coincides with some major advances that happened with breast cancer, most specifically the introduction and then widespread use of mammography, but also the development of certain cancer treatments such as tamoxifen. And when we see this sort of pattern play out where we have the emergence of a disparity and it's following some sort of medical innovation, that really suggests to us that there's fundamental causes at play. So fundamental cause theory is the idea that causes of social inequities give rise to inequities in access to health resources and healthy environments, which then produce poor health and health inequities. So this is a theory that's really looking at some of these upstream determinants, such as policy and programs, as well as social inequities, such as by class, by race, ethnicity, by gender, etc. And it's really something that's looking at the cause of causes. So to sort of conceptualize how this can play out with breast cancer specifically, breast cancer risk and survival are both influenced by modifiable, biological, environmental, and healthcare factors. Some modifiable factors include drinking alcohol, smoking, physical activity, obesity, and giving birth or breastfeeding. Biological factors include aging, the age at menarche, or the age that a woman starts her period, the age at menopause, family history, as well as genetics. In terms of environmental factors, there's exposure to radiation, exposure to toxic waste, as well as pollution. And then healthcare factors include access to health insurance, access to treatments and quality treatments, routine medical care, and access to health facilities. Now, risk and survival for breast cancer are influenced by all of these factors, and that's true for all women. But the probability of a woman having this factor, any of these factors, is not the same, and that's where the social determinants come into play. So first is the individual socioeconomic context. This is an individual person's income level or educational level, and this can impact all of these risk factors directly. So for example, we know that physical activity is important for our general health and is important for breast cancer. But if you take a low-income woman, she may be aware that she should exercise for her health, but it may be that a gym membership is too expensive to afford, or if she has multiple jobs, she might not have time outside of work hours to engage in physical activity. Upstream of the individual socioeconomic context is the social and physical context. So this is what our neighborhoods look like environmentally or socioeconomically. And beyond impacting this inner ring of the individual socioeconomic context, this can also affect these risk factors. So going with that example of physical activity again, we know that poor neighborhoods have fewer sidewalks and fewer parks. So that means that the residents of those neighborhoods have more barriers to entry in order to engage in any of that physical activity due to a lack of actual space. So they can't run or do any sort of exercises outside due to parks not being available. And then furthest upstream are structural conditions and policies. These are the things that determine why our neighborhoods look the way they do, or why we even have differences by income level or educational level or by class. And beyond impacting these two inner rings, the structural conditions and policy also can impact these risk factors directly. So if we look at nutrition, for example, we know that having a healthy diet is important for living longer in a healthy life and having a better outlook for breast cancer. But we also know that poor neighborhoods have food deserts, but those don't just come up by chance or randomly, but instead the grocers are choosing to not place the grocery stores in those areas due to them being perceived as not worth the investment or not going to bring any sort of value to them. And as a result, the residents of those neighborhoods then have lower access to nutritious foods and may have, as a result, lower quality diet. In terms of environmental factors, we know that lower income neighborhoods have typically been chosen as the site to place industrial facilities or highways. And as a result, the residents of those neighborhoods are exposed to higher levels of carcinogens and toxins. And then, of course, the US is a non-universal for-profit healthcare system. And as a result of that, we have differences in accessing health insurance, treatments, seeing a doctor regularly, or even being able to visit a clinic or health facility due to that. So these are those fundamental causes that I was talking about, these structural conditions and policies. These are the causes of causes. And so what I'm really interested in is historical redlining. Historical redlining refers to a federally sponsored residential segregation policy from the 1930s that was used to expand home ownership in the US following the Great Depression. So the Homeowners Loan Corporation, which was a part of the Federal Housing Administration, graded neighborhoods in cities across the US in order to help guide mortgage lending. So neighborhoods were graded ranging from A, which were considered the best, and those were going to be approved for loans, to D, which were considered hazardous and were to be denied for loans. And these degraded neighborhoods were colored in red on these maps that the Homeowners Loan Corporation created. So that's where we get that term redlining from. It's because these color coding of red. And what's really crucial to understand about this grading system is that the neighborhoods were graded explicitly according to their race and class composition, as well as their land use. So whether the neighborhood was residential or whether it was industrial. And we know that it was done according to these things explicitly because along with Holt creating these maps, they also created for each one of the neighborhoods a little grading sheet that explains why that neighborhood was given that grade. And it explicitly states what the racial breakdown was, how many immigrants there were in the neighborhood, what the income level was like, and what that land use was like. So this is a really specific example of a discriminatory policy being pretty explicit about what its purpose is. And even today, despite this practice being outlawed in the 1960s, we continue to see that neighborhoods differ in terms of social, economic, and environmental factors based on those historical redlining grades. So those non-redlined areas, those A and B graded neighborhoods, they have a lot of parks, they have grocery stores, educational and job opportunities. Whereas the D graded and C graded neighborhoods, those redlined areas, they have higher levels of pollution. They have a lot of predatory tobacco marketing and higher density for housing, as well as lower green space, fewer parks, fewer grocery stores, and fewer educational and job opportunities. So to go over how it could be specifically impacting cancer. So again, we have in the 1930s the creation of these redlining maps where neighborhoods were explicitly graded according to race, class, and land use. And what we're positing is that this helped set up neighborhood trajectories where the A-grade neighborhoods benefited from a good environment, had high access to food and health resources, and were affluent, whereas the D-graded neighborhoods had a poor environment, had low access to food and health resources, and were impoverished. And that this initial segregation was maintained over time, despite this practice being outlawed in the 1968 Fair Housing Act through market forces. So those neighborhoods with the good environment and a lot of resources, they continue to get invested in, whereas the neighborhoods with a poor environment and not many resources are continuously devalued. And it's through this that we get these major inequities in the neighborhood environment and health resources, as well as the creation of a wealth gap, particularly given in the US, wealth is generated through home ownership. And it's through this that we can see cancer inequities across the continuum today. So that includes risk, stage, and survival. So that's really the how of redlining and cancer. But in terms of why we need to be studying redlining and its impact on cancer, first, historical redlining grades have these known relevance to biological factors important for breast cancer. So we know that it has an impact on the environment that could influence breast cancer risk and stage and survival. We also know that it has a lot of influence on socioeconomic features that are going to impact access to treatment and impact that survival outcome. But on top of that, a lot of the US's urban planning and neighborhood development system was determined by this policy, such that many cities are still set up and structured in a way similar to that original grading policy. And as a result, it impacts a lot of people even today. And because it's something that does have environmental and socioeconomic properties to it, it's impacting people through a lot of pathways that are important to disease, including breast cancer. So that means that it's something that could have a large public health impact potentially. So if we can show that redlining is important for cancer and then identify how it's important, how to intervene, that means that we could have a large increase in breast cancer survival and a large decrease in the total number of cases. So I'll cover two studies today. The first is how redlining is associated with current day breast cancer survival. And then the second, we'll be looking at how redlining is associated with current day clustering of breast cancer factors. So for the study focused on survival, we're specifically looking at whether breast cancer survival differs by historical redlining grade. We based this study in New York State across 19 different cities where this policy was implemented. So those are shown here in the points in blue. And we obtained data for all breast cancer cases that were diagnosed from 2008 through 2018, who all lived in these cities. And we assigned each patient a historical redlining grade ranging from A to D based on what neighborhood they lived in at the time of their diagnosis. And then for this study, we defined survival or surviving as living 5 or more years past their diagnosis. So for this study, we compared the survival probability by these different redlining grades. And in our statistical models, we controlled for the city that the woman lived in, the age she was when she was diagnosed, as well as the year of that diagnosis. And then we additionally looked at the effect of healthcare factors, including health insurance and first-line treatments that the patient received, as well as tumor features such as stage and breast cancer subtype, and then finally race and ethnicity. So this study included a little bit less than 61,000 breast cancer cases. And what I'm showing here is the distribution of those cases based on the grade that they were living in. And then the colors are corresponding to the patient's race, ethnicity. And what we can see here is that less than 6% of these 61,000 breast cancer cases lived in an A-graded neighborhood. So that's really clarifying just how exclusive of a designation this grade was. And of these 6% of cases that lived in this A-grade neighborhood, 80% of them are non-Hispanic white. So that's that navy blue color at the bottom. And we can see that as we go to increasingly worse redlining grades, that the proportion of non-Hispanic white cases goes down, whereas the proportion of non-Hispanic black, which is this lighter blue color, as well as Hispanic, which is this turquoise green color, those increase. So we can see that even though this was a segregation policy from the 30s that was outlawed, it's still maintaining a high degree of racial segregation to this day. But nonetheless, these C and D grade neighborhoods are extremely racially and ethnically diverse, meaning this is something that does impact a large array of populations. Okay, so we found that redlining was associated with prognostic factors. So women who lived in an A-graded neighborhood were more likely to be diagnosed at local stage or with luminal A breast cancer, which are more favorable. And women who lived in a D-graded neighborhood were more likely to be diagnosed under the age of 40 with distant stage breast cancer or with triple negative breast cancer, all of which are less favorable. And we found that the probability of survival did differ according to redlining grade. So this is showing that survival probability. So we have the survival probability on the y-axis, and then on the x-axis at the bottom is showing the months from diagnosis. So we're starting from essentially the day they were diagnosed and then following them for 60 months or 5 years. And then each of these colors is representing that different redlining grade. So from this, we can see that all of these lines trend downwards, which is what we would expect. So at the beginning of a diagnosis, everyone is alive, which is why that probability of survival is 1, so 100% alive. And with time, we would expect that that survival probability goes down a little bit. But what we're really looking at here is the differences in the line. So first thing we notice is that the A grade, which is this green line on the top, it always maintains the top position, meaning it has the highest probability of survival across time. And then we can also see that the D grade, which is the red line, is always on the bottom across time, meaning it has the lowest probability of survival across that diagnosis period. And on top of that, we can see that each of these lines are separate from one another and follow that same ordering of the redlining grading system, such that each progressively worse redlining grade results in a lower and lower probability of survival. And we also find similar results when we're looking with our statistical models. So before I go into those results, I wanted to orient everyone to these figures since I'll be relying on these a bit through this talk. So this is called a forest plot, and everything you'll be looking at is these points in reference to this green point, which represents A grade. So this green point and the line through it is kind of what we're comparing to. Now, if the points are to the right of this green point and to this vertical line, that means it's a higher risk of death or a lower survival. And if it's to the left, that means it's a lower risk of death or a higher survival. So here we can see that with each point, it goes further and further to the right, meaning for each one of these increases in the redlining grade, blue being B, yellow being C, and red being D, we find that that risk of death is increasing progressively. And then one last point, so the bars coming out of the sides of the points horizontally, that's the confidence interval, which is the range of plausible values statistically that this survival could be. And that's what lets us know if something is statistically significant or not. So because none of these bars overlap with this vertical line, that's what lets us know that this is a significant value, and that no matter any of these range of possible values it could be, that the survival between this point and this point are truly different. Okay. Hopefully that makes sense to everyone. Okay, so back to these results. So compared to women living in an A-graded neighborhood, living in a B-graded neighborhood was associated with a 29% higher risk of death. Living in a C-graded neighborhood was associated with a 37% higher risk of death. And living in a D-graded neighborhood was associated with a 64% higher risk of death. So again, we're seeing a progressively increased mortality risk for each redlining grade. And even after we control for those healthcare factors, so health insurance as well as the first line treatments, we continue to see that redlining is associated with lower survival, with a D grade neighborhood being associated with 32% higher mortality. And this lets us know that there's something about the neighborhood rather than just the people who happen to live in a D grade neighborhood, have no insurance or low quality insurance and aren't getting access to treatment. This is taking care of that and telling us we still see a mortality risk associated with the neighborhood. So we found that this association differs by race and ethnicity. So we found the same sort of pattern we were seeing before among non-Hispanic white women, where with each worse redlining grade, we see that the mortality risk increases. But we didn't find that redlining was associated with survival among non-Hispanic Black women. So we know that here because if we look at the yellow and red point in the middle, so that C and D grade, we can see that these bars are overlapping with this vertical line, and that lets us know that the range of possible values, it could be include 1 and less than that. So essentially what that's telling us is we can't say for sure, at least based on the statistics, that the women who live in C grade have any sort of different survival probability than the women who live in an A grade neighborhood, and same for D grade. And then unexpectedly, when we look among Hispanic women, we find that these redlining grades are actually associated with improved survival. So women who live in B and C grade have statistically lower mortality risk compared to women who lived in an A grade neighborhood. And we see the same direction for D grade, but because that bar crosses 1, we can't say for sure that that's happening. So in terms of what could explain these differences, there's a few different things to keep in mind. So first is there's multiple forms of discrimination that exist beyond neighborhood discrimination, which is what redlining is. And we know that Black and Hispanic women face many more different forms of discrimination, as well as a higher degree and severity of discrimination compared to white women. So one possible explanation for these differences is that this neighborhood discrimination is really making up the bulk of any sort of discrimination that non-Hispanic white women are facing, which is why we can see this survival effect. Whereas for non-Hispanic Black women and Hispanic women, it's just one of multiple forms of discrimination they're facing. So it could just make up or account for a smaller amount of stress they face. Another aspect that's important to recognize is that in health research generally, there's a lot of evidence indicating that social support or having a sort of communal tie to your neighborhood is protective for your health. And that's been shown with breast cancer as well. And while we know that segregated neighborhoods have a lot of health consequential exposures, one thing that pretty continuously shows up in research is that these neighborhoods have a lot more or stronger social ties and a sense of community. And so that can help buffer some of those health risks that they face. In contrast, we also know that when minoritized women of minoritized groups, so Black women or Hispanic women live in neighborhoods that are majority white and high income, they can face a lot of isolation and potentially even an individual form or personal discrimination, and that has some health consequences. So something that could be explaining this is that the women who are living in these C and D graded neighborhoods may have the benefit of having a lot of social ties that provides protection against some of the aspects of living in a redlined neighborhood, whereas the women living in an A grade neighborhood may face a lot of isolation and even discrimination that's making their health worse, which is why these could be a little bit different than what we would expect. And then finally, for the Hispanic findings specifically, so this is something that's seen in health research generally, such that it's called the Hispanic paradox, where something you'd think would be bad for health among Hispanic groups is shown to be good for their health. And one of the things that is believed to be driving that is that Hispanic as a term is really just an administrative label that's used in health records and governmentally, but it's really masking a lot of different populations. So women from Puerto Rico, the Dominican Republic, Mexico, those are all different areas, countries, and cultures, different socioeconomic statuses. But in terms of what data we have, they're all given the same label. So that makes these sort of findings just a little bit tricky to say for sure that, you know, women who are Hispanic living in these discriminated neighborhoods is beneficial for their breast cancer outcomes. We also found some differences according to current day neighborhood socioeconomic status, such that if you're living in a neighborhood that is currently high socioeconomic status, that could buffer the effect from redlining. So even if it was historically redlined, if it's currently well off, it might not have as much of a difference. So we can see that here, this bottom group are showing lower socioeconomic status neighborhoods. And we can see that this D grade point, this red point, is really much further to the right than compared to these other ones. And that as we go up, we see that for D and C grade, there's a little bit closer to the line, which could indicate that this might help remove that effect from redlining. And then further on this note, so we currently have a study under review where we looked specifically at current neighborhood socioeconomic status. And we found that half of that mortality risk we found to be associated with redlining could be eliminated by improving a current neighborhood socioeconomic status. So basically, if we take a redlined neighborhood that today is currently low socioeconomic status, we simulated that if we improved that socioeconomic status today, that would have a large improvement in survival, such that the redlining-based disparity in breast cancer survival would be cut in half. So basically, this study is suggesting that socioeconomic status and improving that neighborhood socioeconomic status is an important and viable intervention point. And then in terms of more of the breast cancer survival results, so there's a lot going on here, but the point is that we looked at this association according to stage at diagnosis, according to hormone receptor status, as well as triple negative breast cancer status. And no matter how we look at it, we're finding the same thing, which is redlining is associated with lower survival. And you can see that sort of quickly based off of these three plots, just by looking at how every single one of these, we see this rightward trend where each single increase in that redlining grade, the point moves to the right, no matter whether we're looking at triple negative breast cancer or non-triple negative breast cancer, it's always a little bit higher mortality risk. And then finally, we even ran a model where we adjust and control for the patient's health insurance, the treatments they received, the stage at diagnosis, their hormone receptor status, and their race ethnicity. And even after accounting for all of those factors at once, we continue to see that redlining is associated with significantly lower survival. And what that tells us is that there's really something about the neighborhood themselves. And these are not just results that are coming because the people who live in redlined neighborhoods happen to have worse health and lower health care. So overall, this study demonstrates that historical redlining grades are associated with progressively worse breast cancer survival today, and that healthcare factors don't fully explain this association. And in terms of other studies that have been done on redlining breast cancer survival, these are pretty consistent. Some of those past studies estimating a 9 to 60% higher mortality risk being associated with redlining. Okay, so now for the second study where we're looking at redlining with the clustering of breast cancer risk factors. So given that study on survival, as well as these other studies on redlining and breast cancer, all have consistently shown that historical redlining is associated with poor breast cancer outcomes. So that includes lower survival, a later stage at diagnosis, and a higher likelihood to be diagnosed with hormone receptor negative breast cancer and triple negative breast cancer. But breast cancer is a disease, meaning it's got a biological basis. So for this pathway to be true for redlining, if it actually is leading to poor breast cancer outcomes, then it has to be impacting some of these breast cancer risk factors for that to happen. So that's what this study was really motivated by, is to figure out what sort of risk factors that are known to be important to breast cancer are actually associated with redlining and could be driving this factor or this pathway. So for this study, we examined whether breast cancer risk factors cluster differently according to redlining grade. And we considered a lot of different levels of risk factors ranging from biological factors to socioeconomic factors. And what we expect to see is that the redlined areas are going to have more adverse factors and fewer protective factors present all at once. So to do this, we used neighborhood level data across the US and looked at factors that are known to be related to breast cancer risk and survival. And essentially, as we took each neighborhood and we said whether or not it was high risk or not high risk for each of those risk factors. So for adverse risk factors, which are all listed here, we said that a neighborhood was high risk if any of these factors were common. So if obesity was common, we said that neighborhood was high risk for obesity. And then for protective factors, which we have here, we said the neighborhoods were high risk if those factors were uncommon. We then use statistics to figure out how these factors cluster together. So to explain that, you can imagine multiple puzzles have been mixed together. And you can imagine that each factor represents one puzzle piece represents one factor. And basically, this statistical method is figuring out which puzzle pieces go together. And these puzzles, as indicated here, those are our clusters. Then that enables us to compare the clusters according to the redlining grade to see if redline neighborhoods have more clusters than non-redlined neighborhoods. And overall, we found that redlining was associated with the clustering of breast cancer risk factors across the US, with redlined neighborhoods having on average 34% more risk factors present than non-redlined neighborhoods. So this chart is showing the average number of breast cancer risk factors that are present in a neighborhood. And then the red is showing those neighborhoods that were redlined, and the blue are showing those that were not redlined. And we found that this association is true across US regions. So, redlined neighborhoods always have more adverse breast cancer risk factors present than non-redlined neighborhoods, but the disparity differs by region. And we also find the overall number of risk factors differs by region. So basically, we're finding that in the South, they tend to have their neighborhoods have more risk factors present, regardless of redline or non-redline compared to the Northeast. But no matter where we're looking, we're always finding that redlined neighborhoods have more adverse factors present. And then in terms of the clustering, we found two different types of clusters for these risk factors. The first being that behavioral and socioeconomic risk factors would cluster together, whereas healthcare risk factors would cluster separately from those and together. And we found that the behavioral and socioeconomic clusters tended to match the redlining patterns geographically more so than the healthcare factors did. And that would suggest that if we want to implement any sort of intervention to reduce redlining-based disparities, we generally would want to focus on behavioral and socioeconomic factors as opposed to healthcare factors. But again, we find that different places show different patterns, so things need to be specific to each community, and I wanted to provide some examples for that. So this is showing a map of Atlanta, Georgia, and the one on the left is showing the redlining map. So we considered a neighborhood to be redlined if it was C or D grade. So the C graded neighborhoods are shown in yellow and the D graded neighborhoods are shown in red, whereas those non-redlined neighborhoods, those A or B graded neighborhoods, those are shown here in gray. And in the next map to the right, we can see the overall number of breast cancer risk factors that are present. So a darker blue meaning more risk factors present. And we can see that this pattern lines up with the redlining map, especially in the southwest portions of Atlanta, where there's a high number of risk factors present. And when we look to the north, where all of those non-redlined neighborhoods are, we can see that there's very few, if any, breast cancer risk factors present. And when we separate this pattern out, we can see that it's really the behavioral and socioeconomic clustering that's explaining this pattern. So we can see this matches this redlining map more so than this healthcare clustering patterns. So specifically, we can see that there's hotspots for these behavioral and socioeconomic risk factors in the south and west portions of Atlanta, whereas for the healthcare clustering, we see that there's not really much variation going on in Atlanta, and the amount that does, it doesn't really match up to the redlining map. So the result or overall takeaway for this being that for Atlanta, we would recommend they focus on behavioral and socioeconomic interventions to reduce some of those redlining-based disparities they see and to improve breast cancer outcomes. But we see a different story play out in Los Angeles. So here is their redlining map, and we see that the D grade neighborhoods are really concentrated around downtown, as well as this portion to the south, and that the further north and west we go, that's where those non-redlined neighborhoods are. And similar to Atlanta, we see that the overall risk factor pattern seems to match the redlining, such that there's more risk factors present in C and D graded neighborhoods. And the further you go out to those non-redlined neighborhoods, they have very few, if any, risk factors present. But when we separate these, we can see that both the behavioral and socioeconomic pattern, as well as the healthcare pattern, sort of match these redlining maps. So we can see with the behavioral and socioeconomic, we see hotspots sort of around downtown in this lower area. And similarly for the healthcare pattern, we can see a really high concentration of poor healthcare risk factors being present there with that dark green in the center. And similarly for down here. And with both of these patterns, the further out we go, so those north and western neighborhoods, they have very few factors being present. So here in Los Angeles, if they were to try to implement an intervention to reduce these redlining-based disparities, we would suggest that they should look at a combined effect or consider both behavioral socioeconomic factors as well as those healthcare factors, given that it seems like both of these are contributing to that disparity in risk factors. So overall, the takeaway from the second study is that redlined neighborhoods have significantly more breast cancer risk factors present compared to non-redlined neighborhoods. And specifically, we find that behavioral and socioeconomic factors generally match the redlining patterns more so than healthcare factors. So across the board, that should generally be the intervention focus. However, we find a lot of evidence that these things play out differently according to region and according to city. So these sort of interventions really do need to be tailored to the specific community in order to correctly deal with those sort of disparities. Okay, so for the limitations of both these studies, both of them are observational, meaning you can't make any sort of causal interpretations based off of them. On top of that, neighborhoods are a difficult area to do research on. So for example, just because someone lives in a given neighborhood doesn't mean that that's where they're spending most of their time. So they could work in a second neighborhood and spend their recreational time in a third different neighborhood. And those different neighborhoods could all have different levels of pollution exposure or transportation ability. So it's hard to say for sure that these results are playing out as we expect, given that we don't know the neighborhoods where these individuals work or spend their recreational time. And then finally, for the second study looking at the clustering of risk factors, that's really only telling us about neighborhoods. It's not telling us about individuals. So we can't draw any conclusions about the individuals within those neighborhoods. We can really only talk about the neighborhoods. So as an example of that, we know that redlined neighborhoods have more obesity, but that doesn't necessarily mean that a person living in a redlined neighborhood is obese. So that's just an important distinction to call out with that type of study. Okay, so hopefully throughout this talk, this has provided a lot of information and evidence to suggest that redlining is important for current day breast cancer and is something that we need to deal with. But it is a policy from almost 100 years ago, and it's also a policy that became, and a practice that became outlawed in the 1960s, which makes figuring out how to intervene on it a little bit trickier. But that's where I find thinking about the conceptual framework really helpful. And to me, it seems that what is really going on here is the redlining set up these different types of neighborhoods and these different trajectories. And our current housing system and policies today help maintain that separation. So it's really how we can intervene on that, separate trajectory where we could see some sort of advances. And I like to think about these interventions in a sort of hierarchical fashion, which I have displayed here in this pyramid, where the things closer to the top are easier to implement, but may have a lower public health impact, especially on the long term. Whereas if we go further down the pyramid, those are going to be more complicated and difficult, but they may have a higher public health impact. So first is we should be educating on neighborhoods and their effect on breast cancer. So breast cancer patients, survivors, and individuals who are at risk for developing this disease should know that breast cancer is impacted by neighborhood, and it's not a disease only influenced by your lifestyle or your family history or genetics. And knowing that could help inform people so they can maybe change their lifestyle decisions. Further, increasing access to healthcare and quality treatment would do a lot to improve overall survival, as well as to reduce some of these disparities. So while a lot of this work shows that the healthcare aspect is really not explaining the association, we do nonetheless find that it explains some of it. So thinking back to that study on survival, we showed that while if we account for health insurance and account for the treatments that people received, it's not removing that disparity based on the redlining grade, but it reduces it a little. So that means that it does help. So even though this won't be a silver bullet, it's something that is going to help us get there. On top of that, and something that could be really timely and important now, is strengthening social safety nets and improving anti-poverty programs. So these are programs that have been shown to reduce stress, they increase nutrition and quality diets, and they allow people to spend their money on medical care, such as going to the doctor or paying for prescriptions, as opposed to basic necessities. So examples of these include Medicaid, the Earned Income Tax Credit, and the Supplemental Nutritional Assistance Program, or SNAP, which is otherwise called food stamps. So these are things that could help reduce the effect of poverty on their health, including breast cancer. Next is to think about more broadly the neighborhood environment, so specifically improving the neighborhood social and economic conditions. Both in the survival paper, but also this paper I showed a little bit of information on that's currently under review, we show evidence that the current day neighborhood socioeconomic status matters and can be used to mitigate the effect of redlining on breast cancer survival. And that makes sense given that the economic conditions of a neighborhood determine a lot of resources that exist, such as the food as well as food quality, whether there's pharmacies there, clinics, how quality the schools, the quality of schools there, as well as transportation. And on top of that, there's also a lot of evidence showing that social support can be really health protective. And some of these neighborhoods may already have high levels of social support. So thinking about ways or policies that can shore up and enhance social support for the neighborhoods where they already have that, and trying to introduce more of it for the neighborhoods that have lower levels of support. Opposite of that is the physical environment. So we know that the physical environment can have direct effects such as pollution or toxic waste, which can increase the risk of breast cancer or the risk of being diagnosed at a later stage or more aggressive cancer, as well as indirect effects. So if we have locations with parks and green spaces, that may allow people to engage in physical activity more or sit and talk with their neighbors, which could enhance some of that social support or communal ties aspect. And some examples of a policy like this, so I'm based in Buffalo, and we're currently looking into efforts to remove an expressway that cuts through some majority Black neighborhoods and moving that expressway to underground. And the hope is that that would reduce pollution in those neighborhoods, but also the plan is to replace it with a park, which would enable people to engage in physical exercise as well as have some of that communal effect. So that's just one example of a neighborhood physical environment intervention that's been cropping up across the country. And then finally, fundamental to all of this is the housing and urban planning policies that we have. So if we could figure out ways to develop neighborhoods in a way that prioritize health and the well-being of residents, as well as improving and maintaining the quality of a neighborhood, would lead to really strong improvements in health, including breast cancer. So the historical redlining policy, as well as the current housing system, both of those are motivated by maintaining and increasing property value. And what that does is it leads to differential development of land, where you have some neighborhoods that get invested in and get nice park spaces, as well as schools, whereas others are allowed to become dilapidated and become ignored. And that differential development of land and the resources in the neighborhood is really what the root cause is to this inequality we're seeing, this inequality in space in terms of the environment and the socioeconomic resources. And there's many downstream health disparities from that. So this is an area that would require a lot of complicated and long-term planning. But I also think it's something that could lead to really strong improvements of breast cancer as well as health generally. So I want to acknowledge all of the researchers that helped me with this work. Specifically, I'd like to call out Heather Oakes-Balcom and Tia Palermo, as well as Lily Tian and Henry Louis Taylor Jr. They were really crucial in developing and getting these studies off the ground. So thank you again for having me for this talk. And then I included here a link, and the same for this QR code, where you could look up these historical redlining maps. This is a website set on the Richmond University, and these have these interactive redlining maps, as well as those original grading sheets where you can see why neighborhoods were graded the way they were. So it's always interesting to see how your city became developed. And yes, thank you.
Thank you so much, Dr. Lima. That was very, very well delivered. And I appreciate your thinking about our audience and making sure everybody can understand some of those figures. Many of them are project lead trained, so they have some familiarity with that. But Uh, I don't even know what to say, especially, considering, where we are today with cuts to Medicaid and SNAP. I mean, um, it just feels like, this is potentially going to deepen the challenges. Suggestions, thoughts?
Um, yeah, this has been a real test for, sort of creative thinking of what to do about this. But I think an important aspect about this work that I try to clarify to individuals is that, I think generally when people talk about redlining, they assume that it's something that only is going to impact um, African Americans or people who are lower income. And we're really showing that it's happening across the board. So some other studies that I didn't include here is we looked at how some of these neighborhoods changed. So neighborhoods that are currently rich but used to be redlined, they can have some depending on whether they have some sort of environmental exposures there, they can still face these adverse consequences, which makes sense when we think about how the policy was used and how the grades were set up. So it wasn't simply based on race, but it's also based on what sort of environmental exposures existed there. And then after the redlining grades, we know that more of those environmental pollutants got placed in those areas, and then property values go down. So I think it is something that, impacts a lot of people, and shouldn't be seen as, only going to impact a small group of Americans, but is instead something that, when you look at a gentrified neighborhood, it might be nice now, but do you know that it's not, the factory that is now a cutesy, trendy location is not still giving you exposure to these sort of toxins. So my only idea is just hopefully communicating all the different aspects that this sort of policy can impact people and their health, and how it's something that happens a lot more broadly than I think is generally understood.
Right, right. So we have a few questions that came in through the Q&A, and please send more questions. Raise your hand if you have a question. We do have a question from somebody who has raised their hand, Roberta. If you would like to ask your question, go ahead.
I'm not even sure where to begin. It almost seems like Project 2025 said, let me see how many more women we can kill with breast cancer. I'm sorry, but that's exactly what it does. But I have a very specific question. In my neighborhood, we have public housing. It's a public housing authority, NYCHA, and there's two campuses, about over 20 buildings, and they've decided rather than renovate them, they're going to demolish them, which is going to bring much more. They're going to be pollutants, dust, environmental toxins, and the worst thing of it all, there's over 300 mature trees in the neighborhood, and the way they developed this housing was to have open space and have green space. And it's an uphill battle. We can't get, I mean, the developers have outweighed the community people, and they're pushing for this. And all I can see in this, from what you've shown, and this was a really fabulous presentation.
Oh, thank you.
Scary, upsetting, very, very upsetting, but really a brilliant presentation. What I'm trying to figure out is, how do I take this to my elected officials and say, you need to consider this. These are considerations that you need to make when you are making decisions about the neighborhoods you represent. What do you think is the best way to do that?
I mean, this is getting into like a public policy area that I don't have any training on, so I feel like I should probably ask you all about what to do.
Right.
But I mean, I think that going and talking to your representative is helpful. And I mean, I don't know the degree to which politicians listen to empirical evidence, versus like narratives. But I think having something like that where it's like you have this specific example, and especially if you can get in touch with some of the residents that are like, this place that I have affordable housing and I have green space, and now it's going to be replaced with what I assume is going to get turned into these sort of luxury condos and displacement of the community. I think that along with like, oh, by the way, there's some major health consequences to this. Like, why don't we pause and think is something that's really could hopefully be helpful. I'll try to, let me see if I
Can
can.
we get copies of the slides?
Yes, I put them in the in the chat, so you should be able to find them in the chat, but I'll send them as well.
Thank you, Michelle.
But
Thank
so
you for putting
also,
this on. This is
oh
great.
yeah, of course. So for Henry Louis Taylor Jr., he's an urban planner and a historian. He really informs some of the theoretical side, but a lot of his work is on neighborhood development and specifically trying to do it in a sort of equitable fashion that recognizes the original residents of certain neighborhoods and trying to prevent gentrification, but improving neighborhoods. And so some of his work really points to things like neighborhood co-ops or a democratized form of land ownership where a board of a neighborhood owns the land, and then they get to decide what happens to it, as opposed to, the person with the most money buys out and if they have the highest bid. So that's, I think, an alternative that maybe could work, but I imagine that's starting one of those is an uphill battle.
Right. So another question related to, so most of these, I'm guessing, I don't know, but these redlined neighborhoods, are these largely in more metropolitan areas? Because one question related to, is there have you looked at differences by rural versus city, metropolitan city,
Yeah.
because what Aaron says is that you could see where extremely rural areas might struggle to get treatments because of age, proximity to the home, and so on. And
Yeah, so redlining is specific only to the urban areas, so it doesn't, even suburban areas, it doesn't get included. So that is a sort of limitation that this can only really be considered when thinking about really metropolitan urban locations. But I think the pathways that at least I'm using to think about this, those can be true everywhere. So as Aaron stated, rural areas have less access to healthcare facilities, and they're also lower income. So generally, there's a lot of urban-rural disparities where rural populations are facing worse health due to economic barriers, due to transportation barriers. These are communities that might be exposed to high levels of pesticides or other sort of chemicals that could, theoretically be carcinogenic. So I think it's for these studies, it can't apply, but I think in terms of the thought process and the pathway, it's all a similar thing, which is thinking about socioeconomic features and environmental features and how those combine to produce poor cancer outcomes.
Another question is how can we make these lower graded areas safer? So that they'll actually, what can we do? Yeah, right here. So I think you kind of addressed that.
Yeah, so I mean, in terms of the safety thing, so a really, really interesting clinical, well, not clinical, randomized trial that happened in Philadelphia, done about 15 years ago. It's by Charlie Brannis, if anyone wanted to look it up, or I guess I could send it to you. But essentially, they took all of these blighted vacant lots in Philadelphia, and they randomly assigned them to either be the same or to get a minimal sort of physical environment improvement. And their physical environment improvement was just mowing the grass, putting like a foot high little picket fence and adding some park benches. So these are really, low effort changes. And they found these huge differences in perceptions of crime, objective rates of crime, perceptions of safety, stress went down, feelings of communal ties went way up. And it was something that like a lot of metropolitan areas could easily implement, where they just create these nicer spaces for people. So I think that's something that would be really doable, but unfortunately hasn't taken off the way that I think, at least that I would have expected it to.
Mm-hmm. Mm-hmm. You know, I found it really interesting, on slide 26, 27, where you found that difference among Hispanic. And I certainly understand, these labels being labels, and most of these are probably uh, self um, self-described, right? So I mean,
Mhm.
the labels themselves, but that is very interesting.
Yes.
So, I mean, what's your thought on what's driving that? First of all, I
So
mean, yeah, well, go ahead. Yeah.
Well, yeah, so part of it is the label thing, but also, as I said, this is something that comes up in health research a lot. And one of the other aspects that could be playing into it, and we just really don't have any way to check it, which is basically number of generations separated from when the person came to the US and assimilated. So, and this is so across a lot of different immigrant communities, people who come to the US, that first generation, that's the original family that comes, as well as the first generation, their health tends to be much higher than, the average American. And the further successive generations that live in the US, the worse and worse health theirs becomes, and to the point that they then match the average American. So what could be happening with something here that, again, this is conjecture, but I would imagine, these degraded neighborhoods, those are impoverished areas for the most part, similarly for the C-graded neighborhoods. So you could have that people who come to the US and immigrate, they can only afford those lower income neighborhoods, but they have the benefit of that protective effect of not being in the US very long. And the
Mm-hmm.
idea of the US making people unhealthy is related to, we're a pretty sedentary lifestyle. We have a poor diet. And it could be that the women who are living in these A-graded neighborhoods are, in terms of how far they are from when their families immigrated, they could be taking on more of those American qualities of a sedentary lifestyle
Mm-hmm.
or diet. But again, we don't have information on how many generations since the person immigrated, but that could theoretically be part of it, along with this concept of the label and the social support aspects.
Right. So I have one more question, and I know we've gone over, but I wanted to ask you, um, did you look at whether or not there are differences in, for instance, the incidence of different subtype breast cancer? So like triple negative, is that more prevalent so I may have missed it, but
Yeah, no, so we didn't. That's something we're hoping to do coming up. This was only focused on survival. And I don't know if everyone can see this, but there are a lot of studies that have focused on it. So for these three studies, and I can send the papers to you if you'd like. They looked at survival, triple negative, and risk of late stage, all of them finding that redlining is associated with a higher risk of those outcomes. And then this one by Krieger and by Wright, they were looking at incidence. And
okay.
the Wright one was specifically looking at incidence generally, and then incidence by estrogen receptor type.
Mm-hmm.
But those studies are a little bit harder to do since, ideally you would have like to really properly check incidence, you need to have your whole population who don't have it yet and then follow them through time to see who gets it. That's obviously not possible when you're looking at a huge population. And even with the sort of cohort studies that exist that can kind of do that, It's a little bit trickier when you're dealing with differences in socioeconomic status because the motivation factor or ability to participate in research can
Yes.
differ by those. So to do these sort of studies, they have to kind of create, like, they have to use standardization and create a population. So those are a little bit trickier, but there is one study that's looked at incidence.
Well, and that's just a whole nother issue, isn't it?
Yeah.
How much of this research is going to be done under the current administration and with the current priorities? And it's very scary. Thankfully, you did all of your research before 2025.
Yes.
Otherwise, I'm a little worried that we might not have benefited from this, what you've learned.
Yeah.
We're in kind of scary times. So, well, on that very sad note, I just want to thank you again for taking the time, doing a wonderful presentation for everyone. And we look forward to you. I didn't mention this in the very beginning, but you will be coming to Georgetown soon. So hopefully we'll have more opportunities to connect with you.
Yeah, I would love that.
So thank you again, Dr. Lima, and thank you everyone for staying on. And we will follow up with an evaluation survey and also the slides and a recording as well. All right. Thank you, everybody.
Thank you.
Bye.